12. Histories. Chief complaint. Primary medical problem is defined by the patient, important because it focuses the clinical history toward the single most important issue. Chronology. Time element of the history, usually including the onset, duration, frequency, and course of the symptoms. Clinical history. Information available regarding a patient's condition, traditionally comprises data on localization, quality, quantity, chronology, setting, aggravating or alleviating factors, and associated manifestations. Leading questions. Undesirable method of questioning, provides information that may direct answers toward a suggested symptom or complaint. Localization. Determination of a precise area, usually through gentle palpation or careful wording of questions. Objective. Perceptible to the external senses. Quality. Description of the character of the symptoms, for example, the color, quantity, and consistency of blood or other body substances, size or number of lumps or lesions, frequency of urination or coughing, or character of pain. Subjective. Pertaining to or perceived only by the affected individual, not perceptible to the senses. Carl Rogers identified several qualities that appear to be important in establishing an open dialogue. These qualities include respect, genuineness, and empathy. When patients perceive any of these qualities to be missing, the interview may become increasingly difficult. The radiologic and imaging sciences professional should maintain a polite and professional demeanor during the interview, especially when introducing himself or herself to the patient, verifying the patient's name, by using Mr. or Ms. instead of first names, and explaining that a history is needed. Notes should be added to the record, usually as part of the examination or procedure request or requisition. Most patients perceive note-taking as positive because the professional is making it clear that the information being given is important enough to be recorded. Objective data are perceptible to the senses, such as signs that can be seen, heard, or felt, and such things as laboratory reports. Subjective data pertain to or are perceived only by the affected individual. They include factors that involve the patient's emotions and experiences, such as pain and its severity, and are not perceptible to the senses. Objective data are not necessarily more important than subjective data. Never disregard anything the patient says, especially if it does not fit with the opinion you are forming about the patient's symptoms. Effective histories result when the following questioning techniques are used. Open-ended questions, non-directed, non-letting, let the patient tell the story. Facilitation, nod or say yes, okay, go on, encourages elaboration. Silence, to give the patient time to remember, facilitates accuracy and elaboration. Probing questions, to focus the interview, provide more detail. Repetition, rewording, clarifies information. Summarization, condensing, verifies accuracy. All histories should begin with open-ended questions. This technique permits the radiologic and imaging sciences professional to pick up where the patient had left off and provides medically specific information that might not occur to the patient otherwise. Use precise and clear wording. Begin with a question that provides an opportunity for the patient to respond in a manner that reflects their life experience and educational background. A useful tool is to repeat information obtained as a part of the history for two reasons. 1. To verify that the radiologic and imaging sciences professional has perceived the information correctly, and 2. To ensure that the patient has not changed their mind. In many instances, the chief complaint is directly related to the first symptom that is discussed. However, there is a danger in becoming too focused on determining a single chief complaint. Permitting the patient to add more than a single complaint when multiple complaints are apparently valid is important. The Sacred 7. LCQSOAA. LOCSO. L is for localization. C is for chronology. Q is for quality. S is for severity. O is for onset. A is for aggravating or alleviating factors. A is for associated manifestations. Has there been any trauma? Has there been any previous surgery? L localization is defining as exact and precise an area as possible for the patient's complaint. It requires the use of carefully worded questions accompanied by proper touching of the patient. Sometimes localization is not possible because of the nature of the problem. The radiologist should be informed that the pain is non-localized. C. Chronology is the time element of the history. The duration since onset, frequency, and course of the symptoms should be established. This information should be described in seconds, minutes, hours, days, weeks, or months. Q quality describes the character of the symptoms. Examples include the color and consistency of body fluids, the presence of clots or sores, the size of lumps or lesions, the type of cough, and the character of pain. S. Severity of a condition describes the intensity, quantity, or extent of the problem. Examples are the intensity of pain, the number of lesions or lumps, and the magnitude of pain caused by a burn. O. Onset of the complaint involves the patient explaining what they were doing when the illness or condition began. A. Aggravating or alleviating factors should be well defined, including anything that aggravates, alleviates, or otherwise modifies it. For example, heartburn may occur only after a full meal and alleviated by assuming a right anterior oblique position with the head elevated slightly. Associated manifestations find out whether other symptoms accompany the chief complaint in order to determine whether all of the symptoms relate to the chief complaint or are related to a separate condition. For example, the patient may describe gastrointestinal symptoms as a part of, or separate from, a cardiac condition.